Okay, so again, picking back up where we left off, whenever we finished our last lecture, we were getting into talking about STEMI mimics. And STEMI is just an acronym for ST elevation myocardial infarction. So this is kind of our bread and butter when it comes to heart attacks. And we'll get into more detail on STEMIs after we get through the STEMI mimic portion. But real quick, we are going to talk about what ST elevation is and why we are recognizing it. And then we'll come back in more detail to actually talk about our STEMIs and look at examples of after we get through this portion. So the reason that I do teach the STEMI mimic portion before talking about our ST elevation MIs is because so few true STEMIs are actually seen by us. As the study in the last lecture pointed out, STEMI mimics are a much more common finding in the hospital and pre-hospital setting. So that's why STEMI mimics occur in our 7-step method is before our actual spot where we look for our ST elevation MIs, because we want to always have in the back of the mind, could this ST elevation be caused by something other than a myocardial infarction or an occluded artery? So whenever we're looking for ST elevation, basically this is what it is right here on this slide. So we should never have an elevation of our our ST segment. It shouldn't be above the isoelectric line. So you see where the blue, this is what our normal ST segment would look like. It's just flat. It goes from the J point of the QRS complex, or the end of the QRS, right into the beginning of the T wave. There's no movement of that ST segment above the isoelectric line. ST segment elevation is just what it says. It's elevated above the isoelectric line for one reason or another, and you can see that there. And then below, we have our example of what that looks like without the normal wave superimposed on that. That's an example of ST elevation. So here, just another example of what our ST elevation is going to look like. Anything that's elevated above the isoelectric line is considered to be ST elevation. But we have to beware. As we stated in the previous lecture, there's a lot of mimics that we're going to talk about today that we need to be aware of as we're looking at our 12-lead EKG. Causes of ST elevation other than a myocardial infarction. So the question seems to be, how do we do as providers in the pre-hospital setting of determining STEMIs versus non-STEMI activation? So whenever we do have a STEMI, we do have a candidate for rapid transport. Generally, they need to be taken to a cath lab facility, and we're going to call a STEMI alert. The reason for this is whenever we do have a occluded artery, time is muscle. The longer it takes us to get the patient to the hospital and the longer it takes them to get the patient up to the cath lab, the more and more of that myocardium that is going to be damaged. So that's why we generally have systems in place wherever it is that you're going to work. There should be some type of system of activating a STEMI alert to let them know that we are coming in with a STEMI, and so they can be prepared for that. Overall, if you look at the statistics, EMS as a whole has about a 51% false positive rate. So this is meaning that we're calling in STEMI alerts, transporting these patients rapidly to the hospital, and about half the time they actually have a STEMI or a culprit artery that's occluded, and about half the time they don't. So we are wrong half the time, which is not that great. So hopefully with the in-depth look that we do on on STEMI mimics and the causes of those. It'll lead us to, be better at that than we are currently, because that's pretty sobering. There are some downsides of activating the cath lab whenever it shouldn't be, or activating a STEMI alert. It does truly compromise the systems. Whenever the emergency room can't rely on us, or the cath lab people don't rely on us, they're going to get to a point where they don't activate whenever you call in. Whenever we have that true STEMI, we've cried wolf so many times that they don't want to activate the cath lab, because a lot of these hospitals, even some of the bigger hospitals, they don't always have a cath lab team there 24/7. So they're calling people in from home to come into the cath lab at 3 o'clock in the morning to do a heart cath on somebody, and it turns out they don't even have a STEMI. So they'll get to the point where they don't trust us, and it goes to where they don't trust EMS as a whole to activate appropriately. So I guess I just was thinking here, and I've kind of assumption that everybody is familiar with what a cath lab is and what they do there. If you guys aren't familiar, there's a real brief explanation. They usually a cath lab, whenever we have a STEMI patient specifically, they're going to go in under emergent circumstances. They're going to take them in there. They insert a catheter into the groin. They thread the catheter up into the aorta and into the coronary circulation. They put dye in there, and they look at it. It's a radiographic dye. They look at it. They're able to see the coronary arteries with that dye on a radiographic screen. It's kind of like a real-time X-ray machine almost. So they're able to see that dye flow through the coronary arteries as they inject it into the aorta, and then they are able to see where a clot is located that way. And once they find that clot, they'll thread the catheter into that artery, and then either balloon it open. They'll pump it open, put a mesh stent in there to keep it open, or sometimes they'll shoot a little tiny amount of clot busting drug to break up the clot and then stent it. But that's basically what they're doing in a cath lab whenever we are bringing STEMI patients there. Anyway, off that tangent, false activations are also going to weaken true positives, so you're not going to have the confidence in making the call for when you do have the true STEMI, and then it also degrades professional respect. We need to do our jobs right, and that's going to encourage more progressive EMS hospital interfaces. We also, have some more downsides here. We can, whenever we go down the path of a STEMI, we can miss an alternate diagnosis. Some diagnoses that are, just as critical as STEMIs, if not more, such as an aortic dissection or hyperkalemia. Just calling it a STEMI to be safe is not necessarily the right call. It can also lead us down the path of the wrong treatment. Whenever a patient shouldn't be receiving nitro and aspirin, getting it right is going to affect the hospital treatment and our treatment as well. We can also lead us down to taking patients to the wrong destination. Unnecessarily bypassing hospitals that don't have a cath lab is going to damage our continuity of care, and it can irritate facilities as well. We can also stretch limited resources. If you're working somewhere in a rural setting and you're the only ambulance in the county taking somebody that you think has a STEMI out of the county to a cath lab, bypassing the community hospital, and you're leaving that community unprotected for all that time, for no reason. So it's important to, think about that. It also, whenever we activate the cath lab from the field, it's not necessarily going to be reversed by the cardiologist or emergency department on our arrival. They do have a liability. We call a STEMI alert, and we get them in there, and that cardiologist, he's pretty dang sure that this patient is not having an MI, but on the off chance that they still are having an MI, or they do have something going on, and he doesn't take them to the cath lab, that liability is on him. Whenever they come down and the lawyers are saying, well, EMS said that this guy had a heart attack and then you didn't cath him. So it's a pretty off chance of happening, but it is still possible. So those are things that we need to think about. Like I said, it's going to unnecessarily tax the staff and facilities. Unnecessary angiography. Angiography, another term for the cath lab. These are not without risk. Any procedure is going to have a risk associated with it. That radioactive dye that they give you can cause renal and vascular damage. Heart casts can cause punctured lungs. They can cause embolisms. They can cause blood clots. They can cause tears in the vasculature. So we don't want patients to be being rushed to the cath lab unless we're confident in our diagnosis. So and again, rushing people to the cath lab whenever they don't need it means that they aren't getting treated for their actual problem. We need to be confident, and the way that we're going to be confident is by studying these STEMI mimics, so we can determine the difference between them and the real thing. So the issue of false positive catheterization lab activation remains a significant concern because unnecessary emergency coronary angiography is not without risk to the patient and may impose a burden on limited human and physical catheterization lab resources. So this is coming from the Academy of EMS Physicians. We need to do better. So there's, as we've already stated, a lot of downsides, and we can do better as a industry as a whole. So we do have some tools for addressing this. The big one that I like to think about is clinical correlation. A ECG that we have suspicious findings on should be matched to the patient and the physical exam. So what this means is we get a call for leg pain, and for whatever reason we decide to throw the 12 lead on and capture a 12 lead, and we're seeing ST elevation, and our immediate thought is to activate the cath lab. We need to be real cognizant of the fact of what the patient called for. Are they having any acute coronary syndrome symptoms? If not, we need to really evaluate what's going on. Also, our history and risk factors. Is the patient a smoker, diabetic, hypertensive, etc.? Not always available, very rarely available. Rather, is a copy of old ECGs. These are extremely valuable whenever we're looking for a blind. If we see the patient's ECG that they have at home from their cardiologist is really similar to ours that we're getting, then they're probably not experiencing an acute event. And also, serial EKGs are very important. Repeat 12 leads are going to reveal dynamic changes with our times and treatments. We need to be able to see these changes. Seeing the changes happen real time with our treatments and as time moves on during transport will be a very key indicator in supporting our diagnosis. If our ST elevation is worsening through time as we travel with our patient to the hospital, that's a pretty good indicator that they're experiencing an acute event. And if we improve their ST elevation with nitroglycerin usage, this is going to be also an excellent indicator of an event that is, acute. A side note here, talking about our nitro administration. I believe, I don't know if I mentioned it whenever we were talking about when we do our 12 leads, but I did mention that it should be before nitro administration if possible. The reason is there has been several documented cases where an EMS crew has done a 12 lead. They had a chest pain patient. They gave their nitro, and then a couple later they did their 12 lead. Well, they didn't see any ST elevation on it, so they transported their patient. No big deal. Well, what happens is nitroglycerin is a potent vasodilator. And when they vasodilated those coronary arteries, it allowed blood to freely pass through for a moment, and the vasculature or the oxygenated blood reached that tissue that was clotted off by a blood clot for a momentary time while that nitro was working. Well, as the nitro wears off, that clot becomes patent again, and prevents blood flow to the myocardium. So this patient had ST elevation, and they gave him nitro and took their 12 lead afterwards, and the ST elevation had resolved. By the time they get to the hospital, the ST elevation's back because the nitro's worn off, and the hospital is saying, "What you got? Why didn't you guys call a STEMI alert?" So, I mean, that's happened a few times, so it's something to think about whenever you're giving your nitro. Try and get that 12 lead EKG before you give it. Some more tools for addressing our inadequacies are going to be supportive ECG findings. These subtler red flags that are going to support or undermine the diagnosis of a STEMI. Also, expert consultation, uploading our EKGs or sending them to our physicians at the ER is a very valuable tool because we're able to put it off on the next guy. Which is a pretty good way of making sure that we're not going to get in trouble, at least. And obviously, it's going to be a good way to ensure patient advocacy as well. And then last, but something that is always to be taken with a grain of salt is our computer interpretation. So we have a computer interpretation anytime we do a 12-lead EKG that tells what the computer thinks. And it's used basically the computer is programmed with an algorithm that is basically a virtual consult, and it's always there for you for a second opinion to rule in, sometimes rule out a STEMI, and we'll talk about those algorithms in greater detail. But the problem is that no clinical signs and symptoms are completely reliable, and no ECG findings are completely reliable either. The history of patients is regularly fooling us, and so the answer to this conundrum is that we have to look at the whole picture. We have to look at all these things together. Our diagnosis is going to be based on a whole grouping of our data points and not just one single finding. Talking more about computer interpretations, you'll hear varying opinions on them from different places, different instructors. So the question seems to be: are they useless? Should we ignore them at all? Or should we trust them all the time? The answer to that is neither. They're another tool. They're not infallible, but they do have their place. So understanding the strength and weaknesses of our computer interpretations are going to be what allows them to aid us in our diagnosis. Okay, so the GE Marquette 12 SL is the most commonly used algorithm for cardiac monitors. Whenever the cardiac monitors record a 12 lead, they're going to use this algorithm to make a determination. If they find ST elevation, they make a determination on whether or not they think the ST elevation is caused by an acute MI or something else. Most of the cardiac monitors, including Zoll and Physio Control, use this algorithm. Philips monitors use a Philips DXL algorithm. They report similar statistics. Whenever these do print out an acute MI suspected, they are 100% specific and 61% sensitive. 100% specificity is going to mean that there are very few or no false positives. So whenever they do print out that there is an acute MI suspected, a positive test means that an acute MI is present. They do say 100% specific. I have a very hard time reporting that anything is 100% in medicine, but they are very highly specific. Whenever they do say this, it's very likely that there is an acute MI. So they are very good at screening out false positives. The problem is that they're not very sensitive. What this means is that excuse me, just lost my train of thought there. A negative readout whenever we don't have acute MI suspected, this isn't going to be very helpful. Since they are so, the sensitivity is so low, there are a lot of false negatives as well, meaning that you do have an ST elevation MI and the machine's just not picking it up. So, they are machines, they are infallible. They aren't infallible. That's where we come in. So the bottom line is whenever we do see acute MI suspected, it's not very sensitive, but it's very specific, which is what we need. It's very good at screening out those false positives. We do, what's up?
What's up?
You need in here?
We do some training up front.
Oh, no, I don't care.
Webcam or something?
Just a microphone. I can move somewhere else. It's cool. So there are a few caveats to these algorithms that we need to be considering. Number one is that the algorithms that are used to interpret the 12 leads on the computers are very dependent on data quality. They have to have a stable baseline, very little artifact, which means we need to have proper electrode placement. So, for example, out of the Zoll handbook here, you have this quote of poor data quality means interpretation may be adversely affected. So we need to be very cognizant of that as we're placing our leads. And we'll talk about a few things that we can do to minimize poor data quality. A couple other things that can be fooled by SVT. So any interpretations with a heart rate greater than 100, we need to be very cautious. And it can also be fooled by PR depression. So proper limb lead placement, proper precordial placement is a very good start to getting good data quality. We need to make sure, like I've mentioned before, that the limb leads are going on the limbs. Manage shivering as much as we can. Park the truck if it's necessary. Anymore, you can get decent data quality while you're moving if you're on a highway or something, but whenever you're going through town, it is pretty difficult to get good data quality. Advise the patient not to move. Prepare the skin as you need to. Don't be lazy. If the chest needs shaved, shave the chest. Dry them. Using benzoate tincture is a very good way of getting those electrodes to stick on diaphoretic patients. Undress fully from the waist up and stay organized. Keep your electrodes, the wires from touching each other and bouncing around, stuff like that. It's going to give you much better data quality. So our basic model for determining when we have a ST elevation MI is it needs to be significant ST elevation in contiguous leads with reciprocal changes in the setting of clinical correlation. So this all sounds well and good. This is great, but there are some caveats even to this. This is just a basic model. Depending on where you work, they will have a specific protocol for when you will call a STEMI alert and when you won't call one, etc. But for the purposes of this is the model that we're going to be using. Significant means significant relative to the QRS amplitude. So if you have a tiny QRS with moderate ST elevation, this is significant, even though the amount of ST elevation is minimal. The smaller the QRS, the less recognizable your ST elevation is going to be. Contiguous means you need to know your coronary arteries, understand which occlusions are going to make anatomical sense or go together. We already posted a picture of our leads and what they're looking at, what coronary arteries they're looking at, so review that if you need to. This is what we're talking about with the micro voltages. If you look at the top picture, you have a very modest amount of ST elevation. Look at the baseline, you see you have maybe 0.5 millimeter of ST elevation. But whenever you look at the QRS complex, you notice that it's only about 2 millimeters in height. So whenever this picture is blown up, you can see whenever those are expanded out that this is still significant ST elevation, even though even though it's a small amount, because the QRS complexes are so small. This is something that is lost on a lot of people. So you need to be thinking about that whenever you run into somebody with these small micro voltage complexes. Reciprocal changes. These are the most valuable addition to your basic criteria for increasing specificity. You need to look closely because these may be very subtle. Reciprocal changes may also be your only indication of posterior MI. So you need to have a high index of suspicion and consider a posterior 12 lead or V7, 8, and 9. So what this means, and we'll look at some examples of reciprocal changes, but one good example would be whenever we have ST elevation in leads 2, 3, and AVL, we would look for reciprocal changes in leads 1 and AVL. ST elevation in 2, 3, AVF. And we look for reciprocal changes in 1 and AVL. The reason for this is what we're looking for is a mirror image. Whenever we're looking at our ST elevation in 2, 3, AVF, we know that we're looking from the bottom up. 1 and AVL are looking at the high lateral side. So we would expect, not always, but we would like to see ST depression in these leads. This is what a reciprocal change is. And we'll look at examples of that as we move forward. What we mean by clinical correlation is going to be the classics of chest pain, dyspnea, nausea, and vomiting, but we need to be considering everything from dandruff to microdechia. We need to be open. 1/4 to 1/3 may present with unusual or no complaints, especially in elderly patients, diabetics, females, and cardiac history. These are more likely to present atypically, and they do have a worse prognosis. So whenever we are talking to our patients, we do need to be very detailed in our assessments. Whenever we're talking to them, we need to ask lots of questions so we can get a better picture of what's going on. Asking a patient with a cardiac history, whenever we have chest pain patients in general, we need to be asking a lot of stuff, trying to replicate the pain with palpation, ask if it hurts more to breathe, listening to lung sounds, ask them if it feels like their last heart attack, figuring out their cardiac history. There's a lot of stuff that we need to be keeping in mind as we do our assessment. Some more signs that point to MI is going to be the morphology of our ST segment. Most benign elevation, or elevation that is not related to an MI, presents with concave or scooped ST segments. A convex ST segment is a fairly specific indicator of an MI. For ST depression, it's the same thing, just reverse, since we're looking at the below the isoelectric line. This is very specific, 97% specific, and it's fairly sensitive too. So in our example down here, you look at example A and draw a line from the J point of the QRS complex to the apex of the T wave. If there's a straight line and the and the ST segment scoops beneath it. This is a convex ST segment. Likewise, in example B, we draw that straight line and we see the convex ST segment, which is a much more specific indicator of MI. So we need to be thinking about that. Another way to remember that is if you look at the ST segment in section A or example A, and you can notice that it kind of looks like a happy face, a smiley face. Likewise, B looks like a frowny face. So the ST segment does. So if you just remember that smiley face is good and frowny face is bad, that's a good way to remember which one we would like to see. Looking for changes on serial EKGs is a very good way of pointing towards an MI. Acute coronary syndrome is a changing dynamic process of a supply-demand imbalance of oxygenated blood. So consecutive 12 leads should reveal ongoing changes, especially if we're with our patient for a significant amount of time. STEMI mimics are generally going to maintain electrical stability. There are a few that do not, but for the most part, we generally will not see acute changes with STEMI mimics. When it's possible, like we've mentioned, we need to obtain initial ECG prior to oxygen and nitro, performing serial recordings and watch for evolution over time, where our subtle STEMI becomes an obvious one, or N-STEMI becomes a STEMI, etc. So any changes that we see in our ECG from our initial recording should be regarded as a suspicious finding. This is one of the best tools for distinguishing STEMI versus mimics. So my rule of thumb whenever I'm operating on a truck is every time I do a set of vital signs, I'm taking another 12 lead. Every time I do a treatment, I do another 12 lead. I usually take a lot of 12 leads on my chest pain patients. Continuous and early pre-hospital 12 leads can play a crucial role in the eventual care this patient's going to receive. Also, as we mentioned, changes from old ECGs, when available, are from the facility or patient, are a great baseline, but this is only proving a change since the time of that tracing. So if it's 10 years old and they've had 4 heart attacks since then, it doesn't really do us a whole lot of good. All right, we're going to take a minute and talk about Sgarbosa's criteria. This is a pretty useful tool that we can use for looking for STEMIs in the presence of a left bundle branch block. Basically, the way it used to be set was that ACLS, or Advanced Cardiac Life Support, was a class put on by the American Heart Association. And what they eventually ended up saying was that ST elevation MI or new onset left bundle branch block should be treated like an MI. The problem with that was that they had a lot of false cath lab activations because there were a lot of patients with left bundle branch blocks who didn't have any ischemic heart disease. So they had to kind of revise that, and Dr. Sgarbosa developed a criteria and the problem is that whenever you do have a left bundle branch block, paced rhythm, and a few others, it can be difficult to determine if a patient's having a ST elevation MI or not because they have natural ST elevation. So this criteria was developed to determine if a patient has an MI in the presence of these settings. So basically the rule is of appropriate discordance. A QRS with a positive terminal deflection should be followed by a negatively shifted ST and T wave. A QRS with a negative terminal deflection should be followed by a positively deflected ST segment and T wave. And ST elevation and depression should be proportional to the size of the QRS complex. So we'll look at some examples of that and talk about what we're meaning. So here we have examples of 2 QRS complexes. One, the QRS is above the isoelectric line, and then the other is below the isoelectric line, or mostly deflected. These are the examples of the normal ST segment and T waves for these complexes. In our first example, we have the positively deflected QRS, and then our ST segment is negatively deflected below the isoelectric line, and our T wave is negatively deflected as well. Likewise, we have our negatively deflected QRS complex and our positively deflected ST segment and T wave. This is what we expect to see in a patient with a left bundle branch block or a pacemaker, pace rhythm. Any deviations from this are suggestive of MI. So here we have an example. The rule of appropriate discordance is held intact here. We have all of our QRS complexes that are negatively deflected, and we have ST segment and T wave that is above the isoelectric line. The ST segment is shifted to the opposite direction of the terminal QRS deflection, and it increases or decreases relative to the degree of elevation. So we look at this here, and if you were looking at this and you didn't have any knowledge of what you were looking at, you would be thinking, okay, this patient has ST elevation and V1, V2, V3, V4, V5, and ST depression and V6. So, oh my gosh, this is the big one. But this is what we expect to see. We always expect to see the rule of appropriate discordance in these left bundle branch block patients. So here's the principles that we can apply Sgarbosa's criteria to. We have left bundle branch block, right bundle branch block, left ventricular hypertrophy, paced ventricular rhythms, non-paced ventricular rhythms, Wolff-Parkinson-White, and other pre-excitation syndromes. So it is a very useful tool. We can use it for a lot of different things to rule in a ST elevation MI. This is an example of the actual criteria. In the setting of chest pain and left bundle branch block, we need to have concordant ST elevation greater than or equal to 1 millimeter in any lead with a positive QRS complex. Concordant ST depression and greater than 1 millimeter in V1, V2, or V3, and discordant ST elevation greater than or equal to 5 millimeters in any lead with a negative QRS. So what we say here, using this criteria, as we move on to the next few slides, any point, whenever we add our points up, and the first criteria is worth 5 points, 3 points, and then 2 points in the for the third one, anything greater than or equal to 3 is 98% specific for an MI. Not very sensitive, so it's not very good at ruling out false negatives, but it can help us rule out false positives. So this is what we're really looking for. Alright, so we'll look at a graphic here that should help explain it a little better. So here's our first criteria. Looking at the left-hand picture, we see our positively deflected QRS complex, and then we also have positively deflected ST segment and T wave. This is worth 5 points. Our second one here, is our negatively deflected QRS with greater than 5 millimeters of ST elevation. This is worth 2 points. And then our third example is our negatively deflected QRS with a negatively deflected or concordantly deflected ST segment. And this is only in V1, V2, and V3. So this is really all we're looking for. We need to look for these criteria in the presence of a left bundle branch block or any of the other conditions that we were discussing, and this can help us rule in an MI. Talking about discordant ST elevation greater than 5 millimeters, that's the one that's worth 2 points. This is a very controversial rule due to the lowest specificity. Especially we run into problems when we have large amplitudes of QRS complexes, such as in left ventricular hypertrophy, where 5 millimeters may be the normal discordance, and there's nothing abnormal there. So we do have a modification to Sgarbosa's criteria, where we can make it proportional. where we say the discordant ST elevation should be greater than or equal to 0.2 times 1/5 of the terminal S wave. This is creates a reduction in false positives from the large QRS complex, and it helps reduce false negatives with small microvoltage QRS complexes. So we won't, we won't be too bent up on remembering that now. I really do want to drive home Scarboza's criteria, though. Smith's criteria is fairly new. It's only been around for 5 to 10 years, I believe, and it is catching ground. So it's something that if you guys were interested in doing some more reading, it would be a great topic for you to look into. All right, so here we have an example of a left bundle branch block. We have our ST segments that are shifted discordantly to the terminal QRS, and basically this is what we expect to see. This is not positive for Smith or Scarboza's criteria in the presence of left bundle branch block. All right, here's another example. This is a left bundle branch block with inappropriate concordance. We have ST depression in V1 through V3. We have elevation in V5 and V6 and lead 2. We have excessive discordance in lead 3 and AVF. So what we see here is that let's focus on leads 4, 5, and 6 first. We see that we do have a positively deflected QRS. We do have concordant ST elevation, so this is abnormal. This is worth 5 points. Then we look at V1, V2, and V3, and we have a negatively deflected QRS with a negatively deflected ST segment greater than 1 millimeter, and this is worth 3 points. In lead 3, we have a negative QRS complex with greater than a 5 millimeter amplitude of ST segment, and which is worth 2 points. So this is the spot-on example of an ST elevation MI in the presence of a left bundle branch block. It is positive Scarboza's criteria as well as Smith's modification too. This patient had a left coronary and right coronary artery occlusion. So there's some good examples of the anterior septal changes that are reciprocal to a posterior injury. Also interesting to note, we do have a readout of our computerized interpretation. We have, and it says abnormal ECG, normal sinus rhythm with sinus arrhythmia, and left bundle branch block. Computer algorithms will not identify a occlusion in the presence of a left bundle branch block, so it's important to remember that. So, modified or not, using the Smith criteria, the effectiveness of Scarboza has only been studied in the context of 2 rhythms. That's the left bundle branch block and pace rhythms. It's had similar results with the specificity mentioned, but it works for LVH as well. It's the same principle. We just don't sweat the numbers. So now that we have discussed Scarboza's criteria, we are going to go ahead and look at some more common STEMI mimics. And after we get done with that, we will get into discussing our next segment on ST elevation and injuries and MIs. So we will have a lot of information that we're going to go through. As you guys have probably noticed, this is a pretty long-winded PowerPoint. And there's a lot of information in it. So there is some good pictures and stuff. And I don't expect anybody to commit this to memory after recognizing it for the first time. This is really a good lecture to remember everything that's out there that's trying to fool us. So, and it also gives you a good first exposure to a lot of this information. That's going to help us. That's going to help us in the future as we, as you get more familiar and are learning more about EKGs. So we'll get started here. So the first STEMI mimic that we're going to be talking about is left ventricular hypertrophy. This is the single most common STEMI mimic. You may or may not see ST changes with it. Whenever we do see those dynamic ST wave changes, that's when we can confuse it with ST elevation MI. Scarboza's criteria does work well when we do have ST changes. It can be sometimes difficult to determine the actual size of the QRS. You'll notice on most cardiac monitors there is a algorithm that causes the ST or the QRS complexes to be cut off on the top of the page whenever they are too long. I'll show you an example of that. So whenever those QRS amplitudes get to be a certain size, they just have a square box at the bottom and they don't print the entire QRS complex. So you need to watch out for that. So true anterior STEMI is very rare in the presence of profound left ventricular hypertrophy. Whenever it is present, you should know it due to the fact that your patient is going to be extremely hemodynamically unstable. That is the number one recognition point for LVH with anterior STEMI. You may have some benign convexivity of the ST segment. The voltage criteria is generally irrelevant to the question of MI, and the voltage criteria we'll talk about here is you take and what we're talking about is the diagnosis of LVH. Diagnosing it, you'll take the S wave depth in V1 plus the R wave height in V5 or V6, whichever one's bigger, and you will add those together. If it's greater than 35 millimeters, then you have left ventricular hypertrophy. So here we have an example of our LVH. We're going to use our criteria for determining if there's LVH or not. Looking at the S wave in V1, looks to be about 22 millimeters in depth, and we're going to look at V5 and 6, whichever R wave is the tallest. Remember, the S wave is the first downstroke of the QRS complex. And it looks to be V5. It's kind of hard to tell, but that the QRS is overprinted into V4. But if you notice, it looks like it's about 35 millimeters in height just by itself. It goes all the way up to the isoelectric line of V4. So we're looking at, well over the threshold for this to be considered left ventricular hypertrophy. So that's really the point to drive home here. And whenever we do have this, using Scarboza's criteria, we can determine if there's an MI. So looking at we do have some ST elevation, but it is discordant to the QRS complexes in this case, so it's not really anything to worry about. We cannot determine if this, we can't say that this patient's having a STEMI. So we have a couple millimeters of elevation in all of our precordial leads, but it's all discordant to the QRS, so we don't have anything that we can say for sure is ST elevation secondary to ischemia. This example, on the other hand, if you look, we do have some concordant ST elevation in lead 3, 2, 3, and AVF. So this would be 5 points in Scarboza's criteria. We also have concordant depression in V2 and V3, which would be 3 points. And it doesn't look like we have any elevation greater than 5 millimeters, which would be the 2 points. But we do have 8 points, which is enough to determine that this is an ST elevation MI. Again, this is left ventricular hypertrophy. Looking at V1, our S wave depth is 21 millimeters, and then V5 is the largest R wave, and it's 5, 10, 15, 20. So we're about 42 millimeters, which is over the threshold. So this is STEMI in the presence of left ventricular hypertrophy. Left bundle branch block is the next STEMI mimic we'll talk about. This is the second most common mimic. Traditionally, it's either, we talked about earlier, used to the AHA noted that new onset left bundle branch block was the equivalent of a STEMI. Usually it's either considered non-diagnostic or it's just, de facto evidence of an MI. The AHA does still recommend fibrinolysis for patients with presumably new left bundle branch block. So the reason for that is whenever patients have an infarction that's large enough to cause a left bundle branch block, there is an extremely high mortality rate. It's got to be a pretty extensive acute MI to cause that much blockage to interrupt flow from the left bundle. So that's the reason for it. Just remember that now we can use Garbosa's criteria to determine true STEMI from non-diagnostic left bundle branch block. Identifying left bundle branch block, we've talked about this before. We'll have a QRS greater than 120 milliseconds in duration. We have a dominant S wave in V1. We have a broad R wave in the lateral leads, and there should not be any Q waves. So the pathophysiology, what we were talking about with the AHA recommending fibrinolysis for these patients with presumably new left bundle branch block, it stems from the fact that a left anterior descending artery occlusion that is high enough to involve the bundle branches is endangering a significant portion of the myocardium. So you think about where those bundles split off, and the left bundle is just around, just distal to the AV node, which, if you look at the anatomy of the coronary arteries and where the proximal LAD is, you have to have a pretty high up occlusion for the left bundle branch to be included in the necrotic tissue. So this is a huge portion of the left ventricle that's not being supplied with blood. So it's a very significant indicator whenever you do have anterior STEMI in the presence of left bundle branch block. It's usually going to present with some type of hemodynamic instability or cardiogenic shock. Another reason that they recommend prophylactic fibrinolysis is because it is kind of difficult to definitively diagnose STEMI in the setting of left bundle branch block. So pre-hospitally, the result is that new left bundle branch block is often presumed to be AMI until proven otherwise. The problem with that is that a lot of times we really don't know if it's new or not. A patient can tell us that they have no history of heart problems, but we don't know if they had that bundle branch block before we came into contact with them. So that's why it is a good idea to be familiar with Garbosa's criteria so you can rule those in and try and rule them out as well. Like I was saying, even new left bundle branch block is not an indicator of MI. They did do a study in 2008. Looked at 3 groups of emergency room patients with complaints of consistent with acute coronary syndrome. They put them into groups of those with presumably new left bundle branch block, those with old left bundle branch block, and those with no left bundle branch block, and all groups had the equal probability of having an MI. So there's really no definitive way for us to determine with these patients if the new bundle branch block is caused by an MI or not. So, in short, the new left bundle branch block in the setting of MI may be a very high risk indicator, but it is not an indicator of MI. A diagnosis must still occur. And how are we going to do that? We've already discussed it using Garbosa's criteria. That's what it's for, and we know it's worked. So it's been there's empirical evidence to support the findings of Garbosa's criteria in left bundle branch block. Also, serial ECGs are a great way of determining acute changes. Uncomplicated left bundle branch block is generally electrically stable and it's not going to change over time. And then old ECGs are another great way. Old left bundle branch block versus new doesn't really change the probability of MI, but if there is an old left bundle branch block, we can compare it and look for acute changes. Here's our example of the left bundle branch block, uncomplicated. We do have the dominant S wave in V1 with the large R wave in AVL with no Q wave. So if we look here at our precordial leads again, we do see some significant ST elevation due to the size of the QRS complexes, the inappropriate conduction path through the right, that slow cell-to-cell conduction through the right bundle over to the left side causes some repole abnormalities, which gives us this ST elevation. But this is what we expect to see in a left bundle branch block. Now, comparing that with our left bundle branch block in the presence of STEMI, we do see here some changes. We still do have it. We do have an S wave in V1. We're wider than 120 milliseconds, but we do look at lead 1 and AVL, and we do see that we have concordant ST elevation in these leads, which is 5 points on Scarboza's criteria, which is enough to identify this as a STEMI. Looks like we can also go into V5, and it looks like we have some concordant ST depression with the QRS there. Wouldn't be an extra 3 points because the 3-point indicator has to be in V1 through 3. But this is still enough to determine that we have an MI. So this, again, is a very subtle MI that, without using Scarboza's criteria, would be difficult to determine. This is an MI that would be fairly easy to miss due to the small amount of ST elevation. So, a reminder to look closely whenever we're looking at any EKG, but especially those with left bundle branch block. All right, so we'll talk about right bundle branch blocks now. It's important to remember, and I think I mentioned this later on, but the only empirical evidence that has been tested with Scarboza's criteria is the presence of STEMI and paced rhythms and left bundle branch block. But we can still use it in right bundle branch blocks and a myriad of other conditions as well. So identifying right bundle branch blocks, we're going to look for our RSR prime pattern in V1. We should still have a QRS complex greater than 120 milliseconds and a slurred S wave in the lateral leads. Right bundle branch block is the 5th most common STEMI mimic. It's usually easier to manage because it doesn't normally elevate the ST segment like in the common right bundle branch block nearly as much as you see with the left bundle branch block. ST depression and T wave inversion are a lot more common. Just similar to left bundle branch block, morbidity and mortality may be very high when AMI is associated with right bundle branch block due to the large portion of myocardium that is affected. The principles are the same. We're going to use Scarboza, and remember to base discordance on the terminal QRS deflection or the majority deflection of the QRS. And we do need to watch out for posterior reciprocal changes, deepening your normal ST depression. So we look at an example of a right bundle branch block here. We do see some ST depression in our high lateral leads, lead 1 and AVL. We do have some ST, looks like some moderate ST elevation in the inferior leads of 3 and AVF, and some depression in our septal precordial leads. But it looks, this is pretty acceptable for a right bundle branch block. We can't call this a STEMI. Using SCAR criteria, looking at this particular EKG, we are able to say that this is a STEMI. This is a right bundle branch block patient. This is a very extensive MI. We have ST depression concordant in leads 2, 3 AVF. We have concordant ST elevation in leads 1 and AVL. We have concordant ST elevation in leads V1, 2, 3, 4, and looks like 5. And then we have ST depression concordantly in V6. So this is pretty much our home run ST elevation MI in the presence of right bundle branch block. This one, like we discussed, is a little bit easier to determine. from the difference between, rather than left bundle branch block, presence of STEMI and right bundle branch block is a little easier to pick out. Our next STEMI mimic that we're going to be looking at is right ventricular hypertrophy. We've already talked about left ventricular hypertrophy, so this is just on the other side. It's the second verse, same as the first. We're going to use Scarboza's criteria. Only notable differences from LVH. Generally, our right ventricular hypertrophy is going to be most evident from V1 to V3. We'll generally have right axis deviation. Due to the increased size of the right ventricle, we'll have increased electrical conduction on that right side. Presents similar to a posterior wall MI with reciprocal changes, so we need to be aware of that, of determining between the two of them. Diagnosing RVH, we'll look for right axis deviation, a dominant R wave in V1, a dominant S wave in V6, and history is a very big indicator. We need to be talking to our patients about history of lung problems. This is going to be most commonly seen in patients with our COPD or CHF, or not generally CHF, excuse me, our chronic COPD, emphysema, and asthma patients, due to the increased vascular resistance against the lungs. So it causes that ventricle to have to pump harder to pump blood into the lungs. Okay, so here we have our example of right ventricular hypertrophy. This is a right ventricular hypertrophy with strain pattern. We have a dominant R wave in lead 1. We do have axis deviation. Everybody look at your cheat sheets and determine that axis for me. And that's, but this is our typical findings in RVH. So whenever we mention that the common finding in RVH can mimic a posterior wall STEMI, this is what we're talking about. You look at lead V1, 2, and 3. Note the isolated ST depression in these leads. As we talk about posterior MIs, we need to remember that whenever we're looking at the backside of the heart, our traditional 12 lead is not going to show us typical changes that we'd expect to see. So anytime we do see isolated ST depression in the precordial leads, we need to be cognizant of the fact that this could be a mirror image of an MI on the posterior side. Generally, isolated ST depression needs to be, these people are candidates for a posterior 12 lead where we can look for ST elevation from the back. And we'll talk about that more in detail when we discuss these posterior MIs. Again, we have another example here of a pretty typical right ventricular hypertrophy finding. Pretty simple here. We do have concordant ST depression in V1 through V3, but not really any other irregularities. So not really too atypical for an RVH pattern. We do have appropriately concave ST elevation, or excuse me, ST segments. So not really anything to worry about. Looking at our next slide here, we do have an example of right ventricular hypertrophy with in the presence of ST elevation MI. So we see our inferior leads. We do have some concave, or excuse me, convex ST elevation. Looking in V1, we still do have our not a little more subtle case of right ventricular hypertrophy, but the big indicator here is the poor R wave progression in the horizontal axis, noting that we do have a positively deflected QRS complex in V2, which is a little earlier than what we would expect. So fairly easy to pick up on this particular case here. It can be a little more difficult. So we'll move on to our next STEMI mimic here. We're going to talk about benign early repolarization. This is benign, meaning it's a normal variant, otherwise known as J-point elevation. This is a typical finding in healthy adults. It's the fourth most common STEMI mimic.
There is at least some degree of benign variance. It's common in the healthy population, usually prevalent in younger adults, and it's going to decrease with frequency and age. So maybe a little more noticeable in athletes. There are some very common non-specific ECG characteristics, but the changes are generally limited to some features that we'll talk about. Our typical EKG findings with BER are going to be ST elevation in the anterior precordials. It shouldn't be too profound. It should be concave, and you may have a notched J point noticeable mostly in V4. You may also find some asymmetrical T waves that are larger than what you'd expect, movement of the ST segment or T wave on serial recordings, but for the most part, you should not have too much electrical instability. They should remain fairly electrical stable during your time with them. So that's going to be our biggest indicator. Also, we need to be cognizant of the fact that there should be no reciprocal changes. We should not have convex ST segments. We shouldn't see any Q waves. There should be no acute evolution over time, and no clinical correlating signs and symptoms. So in short, besides the ST elevation and big T waves, it really shouldn't look like an MI. A couple more little side notes to help you distinguish benign early repole from anterior MI. Benign early repole is generally associated with a well-developed R wave, and BER is almost always associated with a short QT. So if any of the following are true, it is very highly sensitive and specific for an MI. An R wave in V4 of less than 13 millimeters, a QT segment greater than 392 milliseconds, or ST elevation greater than 2 millimeters measured 1.5 boxes after the J point. So we'll look at an example of benign early repole. Kind of a scary looking EKG whenever you first look at it because of the ST elevation. This particular case is fairly easy to recognize if you look in V4 at the terminal end of the QRS complex. We do see some notching of the J point of the QRS complex. Our ST elevation is modest. We do have a well-developed R wave in V4, greater than 13 millimeters. Good R wave progression, no axis deviation. So this is pretty distinguishable from MI. We don't have any reciprocal changes. All we have is the ST elevation in the anterior precordial leads, which is pretty good evidence that it's benign early repole versus an acute STEMI. Another example here. Again, look at the notching in V4. We have a well-developed R wave in V4. No axis deviation, good R wave progression, no reciprocal changes. Pretty typical finding in a healthy adult. And one more. We have some ST elevation in V2 through V4, it looks like. But again, the T waves are still asymmetrical. They're non-hyperacute. We don't have any axis deviation or we have good R wave progression, and we don't have any reciprocal changes. So another example of benign early repole. And here's a really good example of the notching in the J point of V4. This is a classic indicator of benign early repole. You won't always see this. But looking at the end of the QRS, you do see that notch, which is an inclusive indicator of benign early repole. The best way to determine between benign early repole and anterior descending occlusion is the following formula. This is a formula developed by Dr. Steve Smith, and he created it's kind of a rule of proportionality. This formula can be used to determine between benign early repole and acute STEMI. But, you know, I'm not going to expect anybody to remember that. Not really something that's real practical for us to do out in the field. But still something to keep in mind if you ever have a question after a call of whether or not something was a STEMI, and you can pull this formula out. I've used it several times, and it's pretty handy at times. Okay, so we'll talk about our ventricular rhythms now. Another common STEMI mimic. Paced ventricular rhythms are the only other rhythm with empirical support for Scarboza's criteria other than left bundle branch block. You know, the question is, you know, do people with pacemakers still have heart attacks? They do. You know, you got to follow your rules. You guys should know what a pace rhythm looks like. We looked at them in our previous lectures about when we were doing rhythm interpretation. I mean, there's not really anything new here. You're going to use Scarboza's criteria and follow using serial EKGs and correlate to the patient's presentation. Atypical pacer leads that aren't in the apex of the right ventricle or biventricular pacemaker leads may not fit this model, but those are pretty easy to pick out whenever you see them as well. So here's an example of our paced rhythm with a STEMI. First off, look at V4. V4, you see your pacemaker spikes fairly well in there. And then we're going to look at our sorry, I just lost my train of thought there. Looking at V2, we have concordant ST depression in you know, greater than 1 millimeter, and one of our, you know, precordial leads. That's 3 points, and then we have concordant ST elevation in our inferior leads, which is 5 points. And it looks like we have the full ringer here in V3. It looks like our ST elevation is greater than 5 millimeters, so this would be a full-on 10-point Scarboza criteria, which is indicative of STEMI. Left ventricular aneurysm is a pretty common finding in patients that are post MI. It's referring to the persistent after effects of an MI, which often include chronically elevated ST segments. You may or may not actually it may or may not actually entail an aneurysm, which would be the bulging of a weakened section of myocardium or the coronary artery. It can present essentially identical to an MI because that's what it was. You're seeing the after effects of an MI. Somewhat common in the anterior leads, and you know, our biggest indicator here is looking into the past medical history, including a recent MI and an old EKG is available. This is what's going to help us rule this in. Some believe this to be an actual mirror image or imprint of the previous MI. The mechanism exactly is not known. What causes these looks. Our biggest clues are going to be looking for Q waves. Since this is an old infarction, we should have pathological Q waves. Looking for a substantial negative QS wave with no noticeable R wave is going to be a good indicator. And you should not see any hyperacute T waves because there's no acute ischemia. The T waves should not be altered. This can be days to weeks following an MI, so depending on how long it took them to seek treatment and how extensive the MI was, will determine how long this is present following the MI. So, in other words, you're going to compare the QS depth to the T wave height. The first should be relatively large, and the second should be relatively small. Otherwise, you should suspect MI. The amplitude of the T wave should be no more than 0.36 times 1/3 of the QS depth in each lead. If the ratio is greater, suspect an MI. Here's an example of a anteroseptal aneurysm. Looking at our precordial leads, we see ST elevation in V1, 2, 3, and maybe 4, but we don't have any hyperacute T waves. We also have a very exaggerated QS wave in these leads as well. So another example here of an inferior aneurysm. Looking at our 2, 3, and AVF, we see the ST elevation with no hyperacute T wave. And we have the Q wave, the QS wave, and looks like 2 or 3 and AVF. So another important thing to remember, guys, with a recent history of an MI, the likelihood of having an MI after having a recent one is pretty rare. Usually these patients are going to be so inundated with pharmaceuticals like Plavix and heparin that it's very unlikely that they're going to throw another clot. So using your history is going to be your biggest indicator on whether or not they're having an acute event or not. Pericarditis, we've already touched on a little bit. It's the inflammation of the pericardial sac. It's often an infectious disease. Clinical signs are suggestive, although they can be kind of non-specific at times. Chest pain is generally sharp and pleuritic, whereas our acute coronary syndrome chest pain is usually a dull pressure. Pain is usually alleviated by sitting up or leaning forward. May be associated with signs and symptoms of infection like fever, increased white count, and there's generally a friction rub that's appreciated on auscultation of the heart tones, and you're not going to find any relief from nitro. Findings in pericarditis are going to be diffuse, non-localized ST elevation, often in all leads except V1 and AVR, which should be depressed. You won't have any reciprocal changes. You'll have widespread PR depression. The morphology usually resembles benign early repole, generally modest ST elevation that's still concave and often notched with long T waves. Generally approach it similar to benign early repole. Your main clues are global ST elevation and PR depression with no supportive signs of ACS like reciprocal changes or Q waves or hyperacute T waves. Pericarditis usually evolves over days to hours. Your first stage is going to have ST elevation, and you'll have a normalization following by a T wave inversion and a normalization. So depending on when you get there, you may see any of these. Here's a common pericarditis finding. Note the ST depression, or excuse me, the PR depression in at the beginning of the complexes there, very indicative of pericarditis, and you do have some modest elevation. So look where your isoelectric line actually runs through. You see the PR segment is depressed, and you have a modest ST elevation. Here's a full-scale example of that. You have the same findings, diffuse ST elevation throughout, PR depression throughout, and you do have pretty much all leads except AVR and V1 where you do have some ST depression. So pretty common finding in pericarditis. There is a caveat to looking at pericarditis. Generally pretty easy to pick up, but we do need to be very cautious. There is a much sinister cause that can closely resemble pericarditis, and that's an occlusion of the left main coronary artery, or acute 3 vessel disease, which causes injury and death to nearly the entire left ventricle. So if you see widespread ST elevation or depression and start to think pericarditis, consider 2 things. Acute coronary syndrome with global ST elevation is very dangerous. This is a very high mortality injury. The majority of the time, patients presenting with ST elevation in most or all leads are not having an MI. So we need to put everything in a clinical context. These patients will usually look terrible, and so will their rhythms. Pericarditis should show ST depression and AVR, whereas left main coronary artery occlusions are going to show ST elevation. Elevation in AVR greater than in V1 is about 80% predictive for a left main occlusion. So think about that and put it into context with the patient presentation. Despite their acuity, left main coronary artery patients need a facility with PCI and CABG. Thrombolysis is not going to be beneficial. Mortality is over 70%. So, do your best and treat with high speeds to appropriate facility. So the key point to remember there, widespread ST elevation with elevation in AVR with the clinical context of a patient that's hemodynamically unstable. Could be a left main coronary occlusion, so treat these patients accordingly. Usually pericarditis patients will be hemodynamically stable. Another thing I thought I had it in here, but apparently not, is a recent history of streptococcus infection. Strep throat is a very common predecessor to pericarditis. So any recent history of an infectious disease should, with a complaint of chest pain or something related to that, is going to be an indicator of pericarditis. All right, now that we've discussed some of those, the most common STEMI mimics, we're going to get into some less common ones. We'll talk about these particular findings here, Brugada syndrome, brain injury, all of these here, and discuss the findings that we'll see in those. After we get done with that, we'll start talking about our ST elevation MIs and what those look like. Brugada syndrome is a distinct combination of ECG findings. Found it is a risk factor for sudden polymorphic VTAC and VFib. It was initially noticed in 1992. It's well studied and it has been found to be genetic. It's the only confirmed cause of sudden unexpected death syndrome among young males in Southeast Asia. You will notice that this is much more common finding in Asian populations than in Caucasians. There is a risk of sudden arrhythmia and possible death. It is worse if there is a family history of syncope or a personal history, but it may be upwards of 8% per year. Treatment is a electrophysiology study and an implanted cardiac defibrillator. Brugada syndrome has a pretty specific ECG findings. You'll see ST elevation in V1 and V2, sometimes V3, and there's a very particular morphology. It has a similar appearance to right bundle branch block, and the appearance may fluctuate over time, and EC changes may be inducible by certain antiarrhythmics, but the hallmark morphology of this ST elevation is usually most visible in V1 and V2. Okay, so here we have our examples. There is 3 types of Brugada syndrome, and there's multiple subtypes as well. But look at our ST segments and lead on type 1. Look at our ST segments in V1 and 2. And this is a very distinguishable finding. With generally you'll have a normalized ECG with isolated ST elevation in V1 and V2. Should not have any reciprocal changes. And generally these, the most common way that you'll run into these patients is with a due to a syncopal episode. So don't expect to find these patients having acute coronary syndrome-like symptoms. An example of Brugada type 1, look at our isolated ST elevation in V1 and V2, that characteristic sine wave ST elevation with no reciprocal changes, no really any specific findings other than that isolated ST elevation. Generally, if you have these patients, and the big thing why this is important to remember, if you run these patients and they're, a healthy adult and they have no history and they started having syncopal episodes and you notice this is something that, it needs to be addressed by a cardiologist because the treatment is in the EP lab. They do need further treatment. They do need evaluation by a cardiologist. So something that you can pass on to them. The only time I've actually run into this was after a syncopal episode and the patient was wanting to refuse care. After showing him, what was going on and explaining the situation, there is a very high risk of sudden cardiac death. So, it's something that does need to be addressed by cardiology. As previously stated, there's 3 subtypes of Brugada syndrome. We're not going to look at them all today. The type 1 is the most common. The ECG is not only diagnostic criteria, this is hereditary. Death in the family from cardiac problems less than 45 years of age is an important predecessor. The most important note, like I already said, treatment for Brugada is an implanted cardiac defibrillator. The bottom line here, Learn the basic morphology, screen for it on all your ECGs, especially on younger patients. Make it a part of your differentials for syncope in young, healthy patients. And if suspected, monitor it continuously and transport to a cardiac facility. Brugada is the evil twin of benign early repole. Your 12 lead may be the only chance to catch a young asymptomatic Brugada patient early. All right, we'll talk briefly about brain injuries and intracranial hemorrhages. Head injuries can induce a lot of cardiac dysfunction. There is generally some degree of heart failure in most anoxic and traumatic brain injury patients. It's thought to be the result of myocardial stunning, possibly resulting from some type of neurogenic vasospasm of the coronary arteries. The effects are typically transient, but they may not necessarily be benign, may still require treatment. ECG signs can be variable. They can include ST changes, giant inverted T waves, otherwise known as a neurogenic T wave, or Osborne waves as well, which we'll discuss shortly. The bottom line here, the primary point is not to be confused if you see ECG abnormalities when assessing the brain injury patient. Consider the circumstances, but the likelihood of concomitant ACS is very low in a brain injury patient, but you still need to monitor these patients for cardiogenic shock because they may need cardiovascular support in the immediate injury period. All right, we'll talk about thoracic aortic dissections here. Diagnosing a thoracic dissection is very critical due to its high mortality and the potential for rapid deterioration. Generally, it can be complicated by its similarity in presentation to an AMI, including the ECG findings. Distinguishing these two is very critical due to very, very different treatment paths. So determining our destination and the appropriate facility could be very different. Transporting to a facility that has PCI capabilities, they have a cath lab, but they don't have cardiothoracic surgery available is a very poor decision on our part. So recognizing these specific specific deviations from aortic dissection and coronary arteries, or acute coronary syndrome is very important. The mechanism for ECG changes is an actual physical impingement on the coronary arteries. You can have a retrograde dissection. So basically, you think about where your thoracic aorta is. It branches out, the left ventricle after the aortic semilunar valve, and then it has the big arch. You have your aortic arch with multiple arteries branching off of it that supply the brain. Okay, so you have a dissection of this artery, and this is the largest artery in your body, and it actually dissects down into the aortic sulcus, which is where our coronary arteries arise. You can have a retrograde dissection of all of your coronary arteries, just like the dissection is occurring in the aorta. So it's pretty easy to recognize that this is a highly critical situation. Clinically, there's really no highly diagnostic signs to determine between thoracic aortic dissection and AMI. Usually the description of pain is abrupt. It's maximal at onset, and it's going to be the worst they've ever had. 40 to 60% of these patients are going to describe it as a sharp or tearing pain, and a lot of them will localize the pain to the chest, and it's going to radiate to the back. Hypertension is present in the majority of these patients, and pulse or blood pressure differential is not really sensitive or specific. If you run into these patients that are having a thoracic dissection to the point where they're hypotensive, be prepared to treat the patient as a cardiac arrest. ECG findings, generally they're going to have LVH baseline because the biggest predecessor to a thoracic dissection is chronic hypertension. 8% of these will show ST elevation. Generally, the ST elevation is going to be global in all leads, which we were talking about, which can be from the left main coronary artery occlusion or pericarditis. So you really have three things that you need to think about whenever you do see global ST elevation. Remember the specifics for determining between pericarditis and left main occlusion, and you can apply those to kind of lump left main occlusion and thoracic dissection in the same arena. So whenever you do have that global ST elevation, consider the fact that you may have a retrograde dissection of your left main coronary artery, which is a very high mortality disease process. 42% of these patients are going to show some form of ischemic changes because they do have ischemia, but it's not due to a thrombosis. It's not from a blood clot. It's from the massive blood loss from your aortic dissection. 75% of the times, these ischemic changes will be located in the inferior leads, and the rest will be in the lateral leads. This is a high-stakes diagnosis, and there's really no good solutions. Always have a high index of suspicion. This should be in the back of your mind on all your chest pain patients. So if you have a history and clinical picture that leans towards thoracic dissection over MI, weigh the risk versus benefits and get to a hospital with surgical intervention as fast as you can. Okay, so here we have an example of a EKG in a patient that was experiencing a thoracic aortic dissection. You look here in your inferior wall leads, it's very difficult to distinguish this from an inferior wall MI. You do have ST elevation with some reciprocal changes noted in lead AVL. Your biggest indicator here is the hemodynamic instability and your history. Something to consider as you look at your EKGs. This is a pretty close resemblance to just a typical inferior wall MI, but the sudden onset of pain, the tearing, sharp pain that they have, and something I don't believe I mentioned earlier is that these patients will have can have some neurological deficit as well. Whether it be acute paralysis or acute, tingling of the hands and feet. This is highly suggestive of thoracic dissection and should be taken quite seriously. So whenever you have a rapidly deteriorating, this should be in the back of your mind that maybe it was not an acute coronary syndrome and it could be something much more sinister. All right, the next one we're going to talk about here is Prinzmetal or vasospastic angina. This is an idiopathic disorder, involves the spontaneous vasoconstriction of coronary vessels. Typically, it's distinguished from angina or your typical ACS angina from the fact that it has an arbitrary onset. It's not going to be related to exercise or exertion. Often it occurs in the setting of coronary artery disease, but it produces symptoms that are disproportionate to the degree of stenosis. So typically it's going to be benign unless it's very severe, but it can contribute to poor outcomes whenever it is concordant with coronary artery disease. ECG findings, usually you'll have ST elevation, typically minimal, 1 millimeter or less, but you can occasionally have severe ST elevation with T-wave inversion. You may recognize inverted U waves. It's a transient duration, generally relenting within several minutes. The ECG changes generally normalize with the termination of the episode, although you may see some continuing T-wave inversion persisting after the episode is over. So atypical or not, it's still angina. It will look and it will smell like angina. Nitro will be very effective. It will pass. One more reason for serial EKGs. Signs and symptoms generally are greater than 10 minutes or more suggestive of an MI. It may not be distinguishable from an aborted or stuttering MI. And these patients do need cardiac care, so you need to play it safe and transport to the appropriate facility. What I mean by a stuttering MI is an embolus that is caught in a coronary artery, but it resolves itself whatever way it does. by relinquishing it from the system before it is able to thrombolize. All right, we've already talked a little bit about Wolff-Parkinson-White syndrome. We'll just discuss it in more detail here. Like we've already mentioned, it's caused by an accessory pathway. It allows pre-excitation of the ventricles outside of the normal conduction pathway. Generally, you're going to have transverse conduction. Morphology resembles somewhat a bundle branch block and can produce ST elevation for the same reason. There is a risk for sudden cardiac death in the setting of arrhythmia, generally in the setting of the reentry rhythms and in the presence of AFib. The diagnosis is important for two reasons. We need to be able to distinguish it from MI and then provide the appropriate antiarrhythmic treatment. We will talk about antiarrhythmics in the next lecture, but we'll go ahead and mention now that these patients with Wolff-Parkinson-White, when they do have a atrioventricular reentrant tachycardia, are not candidates for digoxin. They're not candidates for lidocaine. They're not candidates for amiodarone. They should not have adenosine. There's not very many antiarrhythmics that these patients should have because they can cause a transient increase in heart rate. The only recommended antiarrhythmic for Wolff-Parkinson-White with SVT or AVRT is procainamide, which is not carried by most EMS facilities today. Hello? Okay, so our EKG findings with Wolff-Parkinson-White, we've already looked at it a little bit, but our most distinguishing finding is going to be a slurred initial QRS complex, that delta wave that we discussed. We'll have a short PR interval, a generally borderline wide QRS, and we can't confuse it with LVH. The ST elevation is generally going to be discordant from the terminal QRS deflection. So the bottom line, the first thing we need to do is recognize the pre-excitation. Scarboza is generally going to work in most cases, but there's no empirical evidence of that because each accessory pathway in an individual is unique. So conduction is going to be unique as well. So you can approach it similar to left ventricular hypertrophy, but keep an open mind. If you do have a diagnosis of WPW or there's a history of it, be pretty skeptical about ST elevation MI because symptoms are much more likely related to an arrhythmia than they are MI. Generally, these patients are not going to have ACS on top of Wolff-Parkinson-White syndrome. Here we have an example of it. Number one, note the short PR interval. We can notice that in all leads. It looks like our delta wave is going to be most distinguishable in our limb leads. Look at lead 2, AVF, lead 3. We can see our delta wave pretty well here. Note that we do have some discordant ST elevation in our precordial leads, but this is normal to our type 1 or type A WPW. Also look at V2 and V4. We can appreciate our delta waves there. All right. Another good example of Wolff-Parkinson-White. Look at the large amplitude QRS complexes in our precordial leads. We do have a delta wave. That's pretty. It's appreciated, and looks like pretty much all our precordial leads it's standing out pretty well. So you'll notice here we do have a couple of different types of WPW. There's actually more than 2 types. I just have the 2 types here. But this is based on the R-wave progression. That's where we are able to ascertain where this accessory pathway is located. But not something that we need to concern ourselves with at this juncture. Here's an example of WPW type B. We do have our short PR interval, our wide QRS complex with delta waves appreciated in our lateral precordial leads. All right, we're going to talk about hyperkalemia. All right, so here we have an example of our changes that we'll see in hyperkalemia, looking at our left, and then what we have in our typical anterior MI setting on the right. So on the left side, note that we do have some ST elevation. The biggest thing that we want to remember is that we need to look at our T waves. Our T waves are hyperacute on the right side, but they're not nearly as peaked as they are on the left side. Our peak T waves that look like a mountain peak are generally going to be a good indicator of hyperkalemia. So remember that as you're looking at your EKGs with a history of renal failure, if they have dialysis. Generally, the most common hyperkalemia patient that you'll come in contact is with somebody that's missed dialysis appointments and their electrolytes are deranged. So we'll look at a couple real-life examples. Okay, so here we have an example of a EKG on a patient with a potassium level of 7.1. If you're not familiar with the normal potassium level, it's going to be 3.5 to 5. So note that we do have some widespread ST depression. It looks like some elevation in our inferior leads as well. But note the peak T waves in our anterior leads. We do have, where our ST depression is located, we do have some extremely peak T waves, which should be a good indicator of our potassium problem. Okay, so here we have a little more dramatic representation of our potassium level recognizable on the EKG. This is a potassium level of 8.5. We do see some widespread ST elevation with our peak T waves. Remember the reason that we see this the changes in our EKG with an increased potassium level, and we'll see it in a decreased potassium level as well. But the reason for that is we have potassium is a very important electrolyte in the functioning of the heart's conduction system. So any increase in potassium is going to create conduction delay. So we do have this pretty serious repolarization abnormality, which is causing our T waves to look like this. Here we have a potassium of 9 plus. This is what we call sine waves. Look at how wide and slow this conduction is occurring. This patient is extremely critical as well and requires immediate therapy. At this point, you're kind of at the end of where our myocardium is able to pump effectively. Any potassium this high is going to seriously inhibit cardiac output. So these patients require immediate intervention. At the end here, we have what we're looking at. And why this is a little difficult to distinguish from our anterior MIs. So we look at our precordial leads, the anterior leads. Note that we do have some ST elevation here with it almost looks like a peak T wave, but the thing to remember is they're not going to be as dramatic of a peak, and we do have some more defined ST elevation here. The other thing we can do is look for reciprocal changes, which we do have in leads 2, 3, and AVF. We see that we do have ST depression here, and we should not see any reciprocal changes if hyperkalemia is the cause of our arrhythmia. So the bottom line on hyperkalemia, we should have it in our differential diagnosis for any dialysis patient with general malaise complaints or altered mental status. The most diagnostic ECG change is going to be a peaked and narrow T wave. More advanced changes become less clear. The QRS begins to resemble a bundle branch block or ventricular rhythm. It should be obvious that there's something going on with other than an AMI. We need to guard against our arrhythmias. These patients are at high risk for RNT phenomenon and incitation of VFib and VTAC, and we need to guard against arrhythmias by giving our medications such as calcium and bicarbonate fluids. Okay, real quick, we'll talk about Takotsubo cardiomyopathy, also known as stress cardiomyopathy, transient apical ballooning, ampulla cardiomyopathy, or broken heart syndrome. Takotsubo is a pretty interesting disorder. It's really recently been recognized, and it was first noticed in Japan. 90% of these cases are going to occur in postmenopausal women. Often they don't have much cardiac history. Basically, you have a transient apical ballooning, myocardial stunning of the ventricular apex. This causes the heart during systole to resemble an octopus pot, which is how it got its name. The hallmark feature is going to be an onset of the hallmark feature of this is the onset of pain being provoked by stress or emotional trauma or physical or chemical trauma. So that's really, our history is going to be our biggest indicator here. Basically, Takotsubo can resemble an MI in pretty much every respect. You can have clinical symptoms that appear to be an MI. You can have ECG changes similar to MI. Our cardiac labs can be suggestive of an MI. Basically, the diagnosis of Takotsubo is going to occur when we don't have an acute occlusion. So whenever they do have, these patients are basically going to be treated like they have an MI until they go to the cath lab and the angiography reveals no occlusion. The ECG changes can be resemblant of Prince-Metal's angina with very little ST elevation, but you can still have some bizarre T-wave abnormalities. The mechanism of Takotsubo is not really understood. They're not really sure if it's caused by vasospasm or a neurogenic pathway, but generally the provoking stressor is going to be our biggest indicator. It can be acute or a chronic stressor that spurs this on. With Takotsubo, the biggest factor that we need to be considering is that harm is going to come from acute heart failure. So they can often have a decreased cardiac output, so their ejection fraction can be as low as 40%. So similar to the cardiac stunning that is secondary to brain injury, the prognosis is pretty excellent if the acute period is survived because there's no actual cardiac damage that is being incurred. Generally, they may require cardiovascular support because they can still have cardiogenic shock from the stunning of the left ventricle. Sudden onset of ACS symptoms following some form of stressor, you should be suspicious. But the fact is there's really no way to determine Takotsubo from an MI. Most of these patients will be going to the cath lab anyway. But it is interesting to note that Takotsubo even causes a wall motion abnormality in the myocardium that is recognizable in STEMI as well. So really no definitive way to determine between the two of them, just something to keep in mind. All right, so now we're going to talk about hypertrophic cardiomyopathy, or HOCM. This is a fairly common inherited cardiac disorder, and the disorder includes a transient thickening of the left ventricular wall. Whenever you have a syncopal episode in an adolescent, you should be prompted to evaluate for HOCM. This is a very common cause of sudden cardiac death in youth, and the findings are similar to left ventricular hypertrophy. You can have extremely large QRS complexes with very sharp points on the end. Again, this is the #1 cause of sudden cardiac death in student athletes. You do hear about these cases every year, it seems like. There is increased awareness for HOCM with screening. There's a lot of schools now that are requiring a 12-week EKG be done on student athletes before they're allowed to participate in sports, and this is the reason for that. The incidence is about 1 in 500 in the U.S. with a mortality rate of 1 to 2% annually. Evidence of hypertrophic cardiomyopathy on the EKG is a call for immediate cardiology consultation. Here's Here's an example of it here. Just note, the biggest thing we're going to note here is the left ventricular hypertrophy-like complexes with the extremely large QRS complexes in the anterior leads. If you look, our QRS complexes are actually buried in each other with pretty significant amplitudes. So this is going to be a finding that we'll see usually in younger adolescent patients, and it is cause for a cardiology consult. The digitalis effect can create a wide range of findings on an ECG, even when it's in the therapy range. Digitalis toxicity can cause a lot of different arrhythmias. Pretty much any arrhythmia that we've talked about can be caused by digitalis toxicity. But we're going to talk about the common findings whenever this is in therapeutic range. Generally, you're going to have downsloping ST depression. You'll have a flattening of the T wave and a short QT interval. You might also see some mild PR prolongation, and this is where you might see your U waves, peaking of the terminal T wave, and J point depression. So, looking at an example here, the most common that I've noticed, most common finding, is in our lateral precordial leads, is the J-point depression and the downsloping ST depression. So looking at V4, 5, and 6, note that the J-point is depressed below the isoelectric line, and then you have a downsloping from there of the ST segment. So can be confused with some myocardial ischemia, but this is a normal variant in patients that are taking digitalis. Also recognized in leads 2, 3, and AVF. You have that downsloping ST segment as well. Here's another example of the digitalis effect. Not as recognizable, but you do still see your downsloping ST depression and your J-point depression in our inferior leads. Generally, a history of AFib or Lanoxin digitalis use is going to be your biggest indicator to look for this. It is an interesting finding to find on your EKGs. Whenever we come to terms with talking about digitalis toxicity, there are a couple side points that you are able to notice. A common finding around with digitalis toxicity is a yellow or green a yellow or green aura around the eye. Patients will have some kind of non-specific symptoms. Any arrhythmia in the presence of the usage of digitalis toxicity should prompt you to consider this as being the cause of the arrhythmia. Question your patients about recent changes in dosing or abuse or overuse of the medication. All right, we'll talk about Welland syndrome here. This is a fairly rare disease that you'll see occasionally. Basically, you'll see an EKG pattern that is associated with the stenosis of the left anterior descending artery. These patients are very high risk for anterior MI because the LAD is already partially occluded. So these patients really need to avoid cardiac stressors, and they're extreme high risk for sudden cardiac death. These patients are candidates for PCI and CABG. The criteria for Welland syndrome are going to be inverted or biphasic T waves, generally in V2 and V3. This is the big one that you need to look for. Isoelectric or minimally elevated ST segments can be noted as well. You should not have any precordial Q waves because an infarction has not occurred. You should have preserved R wave progression, and there should be recent history of angina with exertion. And the ECG pattern is only going to be present in the pain-free state, and they may have elevated cardiac markers but may not. There's two subtypes here. Type A has biphasic T waves and septal precordials, and type B has deep inverted T waves in the same area. Here's an example of type A with our biphasic T waves. And these are isolated, but they may extend all the way to V6. And then our isolated inverted T waves in V2 and V3, which is type B. Here's an example of a full EKG with type A. Note V1 and V2, V3 as well, and looks like V4. We do have some isolated biphasic T waves here, which could be confused with ST elevation. These patients are at high risk, once again, for sudden cardiac death and need to be transported to a facility that is capable of CABG. All right, pulmonary embolism can have some very specific EKG changes, but it is important to remember that our main finding with pulmonary embolism is simply sinus tachycardia. You may have some other findings. These include right axis deviation, a right ventricular strain pattern, and right bundle branch block. Patients that do have a right bundle branch block in the presence of pulmonary embolism have a very poor prognosis. There is an extremely high mortality rate whenever the pulmonary embolism is in the presence of the right bundle branch block. Now, it's important to remember that the right bundle branch block isn't actually caused by the embolism. They're separate but related events, but whenever you do have this blockage and the right bundle is unable to adequately pump into the lungs, it does create the perfect storm for sudden cardiac death. So another finding that you may see is what we call S1Q3T3. It's only seen in about 20% of pulmonary embolism patients, but it is very specific for a PE. So if you do see this, you can be fairly certain that the patient does have a blood clot. The findings that you'll see in S1Q3T3 are a deep S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. Here's an example of that. So looking at your lead 1, you do have the deep S wave. Lead 3 has the deep Q wave, and then also an inverted T wave. All right, so the question is, how do you really make sense of all these different STEMI mimics? We need to approach all of our patients with a standardized, in a standardized manner, beginning with the patient's history and background. Is the patient young or old? Do they have a history of coronary artery disease? Any risk factors? Past procedures? Is there a provoking event? How likely is a congenital pathology, and is there an old ECG available? Then we're going to consider our complaint. Is this typical for an MI, or would it be more consistent with some other type of etiology? We're going to obtain an early 12 lead, and like we've already mentioned several times, we want to do that before treatment if it's possible. We look for ST and T wave changes and look at how profound they are. What is their morphology? Do we have reciprocal changes? Does the computer agree with our findings? And does the ECG support any other alternate diagnosis? Would our ECG findings explain the chief complaint? Is it more or less likely than MI? If likely, what is the probability of a comorbid MI? What that means, if we do have, like we mentioned, a patient, say they have a Wolff-Parkinson-White disease, and they have a recent history of pre-excitation tachycardia, the odds that they have a comorbid MI in the presence of this setting are pretty rare. So we need to think about that as we're considering what could be going on. Even if we have the idea that this could be caused by an MI, we need to consider the fact that having multiples of these diseases at one time is not very likely. So we need to look at that in the presence of our patient and their history. We need to consider if there's a chance that an alternate diagnosing is more pressing than a STEMI. For example, our aortic dissections in advanced hyperkalemia could actually be more critical than the ST elevation MI. So we need to be cognizant of that as we look at our EKGs. We need to obtain our serial EKGs. That's going to really be a good indicator that guides and confirms our diagnosis. And then we need to weigh our risks and benefits of transporting to the destination, depending on what they may need. So it's always a good idea, if we have a question, to consult our medical control. And then we need to make sure we provide our findings to the receiving staff.
All right, this is the end of the discussion on STEMI mimics. Our next step, we're going to go into step 6, talking about our ischemia, infarctions, and injuries. Proceed to the quiz on STEMI mimics and see how you do. Now that we've discussed our first 5 steps, this is the point in our EKG interpretation where we're going to actually look for our true ischemia, our infarcts, and our injuries. This is the point where we have ruled out any mimics and we're looking for the real thing. We want to look for pathological Q waves, ischemia-induced T wave inversion, and then ST depression and elevation. Pathological Q waves are indicative of old injuries or previous MIs. I think I've already discussed it, but we'll say it again. A pathological Q wave, they're pathological if they are 1/3 of the height of the QRS, or 1/3 of the total width of the QRS, or 1 or more millimeters wide. So here's an example of a pathological Q wave. Looking at it here, it's about half the total height of the QRS complex, about 1 millimeter wide, so this would be pathological. We do need to remember that isolated ST depression in our precordial leads can be indicative of posterior STEMI. ST depression is not always, which if we haven't mentioned before, ST depression is generally a sign of ischemia as well as T-wave inversion. But generally, whenever we're looking at this as a sign of ischemia, it's going to be a global presentation. So it's going to be our strain patterns or ischemic patterns where we have that T-wave inversion in multiple leads throughout the EKG. So in this particular instance, we're talking about ST depression that is localized. Whenever we do have that is just isolated in these generally the anterior precordial leads, we need to do a posterior 15 lead to look for that reverse elevation that I was talking about. So what we're talking about here is we have our ST depression when we're looking from the front, and it's a mirror image of an infarction on the posterior side of the heart. So we have to put those electrodes on the posterior side of the body to see the elevation. Remember that when we are looking at a 12 lead, acute coronary syndrome very rarely presents with tachycardia. Generally, patients that do have an MI and they are tachycardic, we're only going to see that when they are in cardiogenic shock. So if we do have these patients that are hemodynamically unstable, then it is a possibility that it could be from an MI if they're tachycardic. But generally, think other situations before you're pointing to STEMI in tachycardia. Generally not a very common finding unless the MI is significant enough to cause enough myocardial injury to create a cardiogenic shock state. Bradycardia is a much more common finding in the presence of STEMI due to the fact that we have a transient protective measure by the myocardium. Basically, it's trying to decrease myocardial oxygen demand by slowing down the heart rate so that not as much of the tissue is being necrotized or injured from an increased demand state. Also, remember that ST segment is very difficult to evaluate in tachyarrhythmias, so the heart rate needs to be slowed down to really get a good baseline of what the ST segment looks like. The ST segment should never be evaluated in the 4-lead ECG. 4-lead and 12-lead measurements are at different wavelengths.
Diagnostic criteria for the ST segment needs to be done using a 12 lead. We are not able to determine the true ST segment, whether it's elevated or not, by just a simple 4 lead. So at this point, we're going to look at several examples of what we expect to see in our true STEMIs. We can compare these back to what we were looking at in our STEMI mimics to hopefully see the difference. Some of these are pretty obvious, such as this one. Pretty easy to pick out when we see this patient. We see ST elevation in leads 2, 3, and AVF. We see our reciprocal changes in leads 1 and AVL. We also see ST depression in V1, 2, 3, 4, 5, and 6. So this is pretty much a home run when we're talking about our ST elevation MIs. Pretty easy to pick this one out. Here we have an example of acute anterior STEMI. Even though it's not nearly as ugly looking as the previous one, it's just as, or if not more, severe. This is more than likely a proximal LAD occlusion, which is one of our largest coronary arteries. Looking here, we have ST elevation in V1, 2, and 3. Note the remarkable similarities to what we have in our findings of benign early repolarization. The key differences here are that we do have flattening of the T waves in leads 2, 3, or excuse me, flattening of the T wave in lead 2, and then a reciprocal change noted in 3 and AVF with a ST depression and inverted T wave. So this is also note the flattening and ST depression of V5 and V6. This is not something that will be seen in early repol. This is indicative of acute STEMI. Also note that the T waves in V2 and V3 are much more hyperacute than what we generally see in our benign early repolarization. Another example of a proximal LAD occlusion, this one's a little easier to pick out. We have ST elevation in V1, 2, 3, 4, and 5, and 6. And then we have our reciprocal changes in leads 2, 3, and AVF with elevation noted in lead 1 and AVL as well. An example of a inferolateral STEMI. We have ST elevation in 2, 3, and AVF, leads 1 and AVL, and then V1, 2, 3, 4, 5, and 6. This is a pretty easy one to pick out as well. Note that we do have kind of a flattening of the ST segment in most of these leads. We don't really have a convex ST segment like we'd like to see. That makes it a little easier to pick out. But this is a pretty definitive case of acute STEMI as well. Okay, so this one's another one that's fairly easy to recognize. Note that we do have a high lateral STEMI here. Our leads 1 and AVLs where we're showing our ST elevation. And then we have depression or reciprocal changes in 2, 3 AVF. And then as well as V1, 2, and 3. Looks like we have some elevation as well in V5, V6. These are all looking at the lateral side of the heart. So a pretty easy one to pick out here. Our next example is a case of acute inferior STEMI, isolated inferior STEMI it appears to be. We have ST elevation in leads 2, 3, AVF, reciprocal changes in leads 1 and AVL. We also, looks like, that's about it on that one. Okay, here we have an example of an isolated, it's an inferior or posterior STEMI. We have ST elevation in 2, 3 AVF, and then that isolated depression in V2 and 3. We would need to do a posterior 12 lead to identify this for sure, but more than likely we know it's a STEMI, and it looks like it involves the posterior side as well. Here's an example of an isolated posterior STEMI. We note that we don't really have any elevation anywhere, but we do have isolated ST depression in leads V1 through V4. So this patient needs a posterior 12 lead to be performed to see if we have any elevation. So placement of the posterior 12 lead, basically what we're going to do is we're going to take V4, 5, and 6, and we're going to move those around to place them at the same spot as V1, 2, and 3 on the front. So V7 should be located at the posterior axillary line at the same level of V4, 5, and 6. V8 is going to go just at the tip of the scapula, and then V9 will go on the left spinal border. They should all be in a flat plane. And here's what our finding is in the acute posterior STEMI when we have our ST elevation in V7, 8, and 9. That's our posterior side. Note that now we have some elevation there, whereas before we were just showing an isolated depression. So once we get to that back side where the infarct is actually located, we see the elevation. This isn't the case when we're looking from the front side because we're looking at that mirror image through the rest of the myocardium to see that infarct. So we have to move it around to the posterior side to perform a posterior 12 lead. Note that the complexes are a lot smaller in electrical amplitude. This is because there is a lot more muscle and bone right here that the electricity has to pass through to get to the electrode. So it is common to find a lot smaller QRS complexes on the posterior 12 leads. So be aware of that and look for smaller amounts of ST elevation as well. All right, so something that I may have touched on a little bit, but I want to drive this home a little bit further. When talking about our EKGs, especially in relation to inferior STEMIs, we do need to be cognizant of the possibility of a right ventricular wall MI. So what happens is, as we stated quite a while back, the coronary circulation can be different from patient to patient. They can have an inferior wall that is supplied by the left coronary artery, or they can branching off into the LAD and then dropping down, and it's obviously smaller circulation. But overall, it is supplied by the left side of the heart. Or they can have a wraparound coronary artery on the right side that supplies the right inferior wall and then the posterior side as well. So we can run into some problems because the right ventricle is so much smaller and thinner than the left side. Whenever we have a right ventricular MI, what can happen is that we have a very precarious situation. The preload of the heart can be affected, can also affect the coronary circulation, because we have an event where the preload or venous return back into the heart can be affected by some of the treatments we do. So what we need to be considering is that as we are giving our traditional treatments of nitroglycerin, oxygen, aspirin, and morphine, we need to think about what we're really doing. So we have a event where we do have a right ventricular wall MI and the right ventricle is affected. What we need to remember is that the right ventricle really does rely on that blood flowing into it to support its pumping capability. It doesn't have nearly the muscle that the left ventricle does, so it has to really rely on the stretch of the muscle that is pushed into it from the right atrium, which gets its muscle from the venous return, from the vena cava, from the body. So whenever we have this MI on the right side, we need to remember that preload can be affected by our nitroglycerin. So we have an event where the vasculature is attempting to keep up with circulation by constricting down and providing an increased amount of preload because of that affected part of myocardium that isn't pumping on the right side. So the body tries to increase preload by constricting down and increasing circulation into the right atrium, thus the right ventricle, to make up for that loss of pumping capability in the right ventricle. So what happens when we give nitroglycerin to these patients? patients. If they have a right ventricular wall MI, what we risk doing is vasodilating out all of the circulation, the systemic circulation, thus decreasing preload in the right ventricle. Now, in a left ventricular wall MI, this is generally acceptable because the pumping capability is not nearly as inhibited, and we're not going to risk creating a systemic backup. But on the right side, whenever we decrease that preload, it can actually decrease the cardiac output of the right ventricle. When we do this, it decreases blood flow into the lungs, thus decreasing blood flow into the left ventricle, left atria, and left ventricle, which is going to decrease systemic cardiac output. This can lead to profound hypotension and shock states because we lose that preload on the right ventricular side. So whenever we do have right ventricular involvement in an MI, we need to be very cautious with our nitroglycerin administration. We need to monitor for hypotension and support with fluid therapy as indicated. We don't want to just completely disregard the use of nitro, but we do need to be very cognizant of the effects that it can have. So isolated right ventricular MI is very rare. It does not occur very commonly. It's usually associated with inferior wall MI. So our 2-3 AVF, we need to be very cautious whenever we see an inferior wall MI because 30 to 50% of inferior MIs have some right ventricular involvement. So what we need to do is have a way of determining if the right ventricle is involved. We can do this by doing a right-sided 12 lead. What we do, generally you can do a complete right-sided 12 lead by completely switching your precordial leads around, but generally what we just want to do is use V4 and switch V4 to the opposite side, so it's going to be on the 5th intercostal space, mid-clavicular line, and switch that over to the right side. This is going to give us a real quick picture of what the right ventricle is doing. We should be doing this on all of our inferior wall STEMIs, and this is going to show us if we have right ventricular involvement. If we do, then we need to be very cautious with our nitro administration. Things that point towards a right ventricular wall MI are going to be ST elevation in 2-3 AVF, but also in lead V1. Also, if we have ST elevation in lead 3 that is greater than in AVF, this is very specific for right ventricular involvement. Here we have an example of an inferior wall MI. We see ST elevation in leads 2-3 AVF with reciprocal changes noted in leads 1 and AVL. And we also have ST elevation in V1. And we have ST elevation in lead 3 that is greater than the elevation in AVF. So this patient is a candidate for obtaining a right-sided 12 lead replacement of V4R. Here's the 12 lead of V4R, the circle there where V4 is, that's on the right side, and we notice that we do now have elevation on the right side. So this is confirming that we do have right ventricular involvement, and we need to be very cautious of nitro administration and be prepared for a hypotensive patient and ready to support this patient with fluid therapy and make sure that they and because decreasing that preload when we give the nitro. Okay, so whenever we do have a STEMI, we need to know what what we're going to do, how we're going to handle that. So as we've talked about, STEMI alerts are something that we're going to call the hospital to let them know what we have so they can be prepared by activating the cath lab and preparing resources for what this patient's going to need. So your STEMI alert should be based off some criteria. Generally, wherever you work is going to have their own specific criteria of what you can call a STEMI and what you won't. These are some pretty standard signs right here. So what you want to look for is ST elevation in 2 contiguous leads with a minimum of 0.1 millivolts or 1 small box. you want to look at your computerized interpretation indicating a STEMI with signs and symptoms consistent with ACS on an ECG with good quality. And then you want to consider your ST depression or reciprocal changes and consider Q waves as well. When you do call a STEMI alert, you want to activate as early as possible. You only need to give vital information to the ER personnel. The emphasis on calling a STEMI alert is going to be activation, and then you need to worry about packaging the patient for transport. So giving your vital information here, obviously your name and medic number, advise them of a STEMI alert, a brief synopsis of your ECG findings, the patient's age, gender, and initial complaint, and the patient's preferred cardiologist, the ETA, and time from onset of symptoms. At this point, it is unnecessary to tell the ER staff that you have an IV started, the patient's on O2, etc. The ER should assume that you are following the STEMI protocol. Only advise them of additional information if it's pertinent to the patient's condition or additional treatment that may be indicated. For example, if the patient has acute pulmonary edema and may need to be intubated on arrival, that would be good to let them know. Transport considerations. STEMI patients are candidates for rapid transport. We should take these patients to PCI capable facilities. If you are working in a system with one transport destination, then you should consider that whenever you are transporting your patients. As we've already talked about in multiple different areas of this lecture, patient presentation is step 7, and that's just kind of an overall thought process that you need to be considering on all of your EKGs. Does the EEG correlate to the patient's presentation, complaints, how they look, how they're describing their pain to you, everything? If it doesn't fit, then what fits better? And when in doubt, always consider expert consultation by medical control, and always keep learning. There's a lot of information on EKGs that you can run into, that you can learn about. There's some great texts that you can get if you take interest in EKGs. Really just barely scratch the surface and given a very general overview of EKGs. So, there is a lot more information out there, and I would recommend as you further your career in EMS or medicine in general that you do try and take an interest in EKGs and learn as much as you can about them, as there really is some very interesting stuff out there. Finally, if they all look like this, if every STEMI presented to us like this EKG did, then it would make it a lot easier for us. But they don't. That's the fact of life, and you guys are gonna have to work and learn to identify STEMIs and identify rhythms and everything that we've talked about so far. So this is the end of the presentation. You can proceed to the quiz on step 7 of our 7-step method, or step 6 and 7. And we have one final PowerPoint to go, and that will be the end of the EKG module PowerPoints, and we'll be finished with that. So as always, if anybody has any questions, be sure to let me know, and I'll be happy to help you out any way I can.